This program is brought to you by Emory University.
Good morning, everybody. Welcome to the final Friday morning conference of the calendar year. I want to introduce our speaker this morning, Dr. Leo Knijnik. Leo is a first-year fellow in the clinical track. He's originally from Brazil. He did his residency at the University of Miami, where he was the chief resident. And as I mentioned, is a first-year fellow in the clinical track. I cannot see the screen. I'm currently driving, but long story. But he tells me he's going to talk about early repolarization syndrome. So, Leo, take it away. Before you take it away, one last reminder to the faculty. Again, we're off the next couple weeks. And then also to the faculty and staff, make sure you go and click the blue box on Lori's email so you can claim your CME credit. All right. Thank you, Leo.
All right. Thank you. Hi, everyone. Good morning. So yeah, I'm Leo Knijnik, for those that don't know me. And today I'll be presenting a case about early repolarization syndrome. I have no disclosures. And the learning objectives of this talk are to define early repolarization pattern and syndrome, understand the natural history and the arrhythmic risk associated with early repol, and manage early repol syndrome. So jumping into our case, it's a patient we saw at Emory. It's a 24-year-old man with no past medical history, was brought by EMS after a cardiac arrest while playing basketball. He received bystander CPR and had defibrillation. His rhythm was ventricular fibrillation. And then he was brought to an outside hospital, and this was his presenting EKG. So basically you see right axis deviation, QRS notching, and ST elevation in the inferior leads. In that hospital, coronary angiography and cardiac MRI were performed, which were normal. This was the cardiac MRI report, basically normal LV ventricular size and function, no signs of scar, infarct, or infiltrating cardiomyopathy, and the RV was normal too, no signs of ARVD. This was the EKG on presentation here to Emory, so pretty similar with these ST elevations in the inferior leads with QRS notching and slurred ST elevations. And then 30 minutes after presentation, similar EKG. Then the patient underwent a diagnostic electrophysiology study. So sinus node and AV node conduction were normal. Infrahystian conduction was normal. Atrial arrhythmia induction was negative. And for ventricular arrhythmias, programmed stimulation induced monomorphic VT. The patient also underwent procainamide challenge provocation testing in the EP lab. This was the presenting EKG, so very similar to the one that we saw initially. And this was the IV procainamide testing was to see if the patient had Brugada pattern. So you see that with IV procainamide, a non-specific finding was noticed, which was the ST elevation in the inferior leads actually became more pronounced, but the patient did not meet criteria for Brugada because of, even though he maybe had an incomplete right bundle, there was no ST elevation in leads V1 and V2. This is 5 minutes, 10 minutes. So then the patient was diagnosed with early repolarization syndrome. A subcutaneous ICD was placed. We chose subcutaneous because usually early repolarization syndrome is associated with ventricular fibrillation, and it was felt that the patient wasn't going to need a transvenous pacemaker, a transvenous ICD. Subcutaneous was fine. Genetic studies were ordered, but unfortunately they're still pending at the time of this presentation. So what is early repolarization pattern? And this is the purpose of the talk. It's a very simple definition. There are many definitions, but this is the most widely accepted. It's J point elevation of at least 0.1 millivolts or one small box in two adjacent leads with either a slurred or a notched morphology. So what is slurred and notched? So here in panel A, this is a notched morphology. So you see JO represents the J point. So there's increased ST elevation creating this notching pattern. This is the notched pattern. And then the slurred is, of course, you also have J-point elevation, but it doesn't, the ST elevation doesn't get more pronounced, just kind of slurs down, or it's flat, but there's no upward ST deflection. We'll see later why this is important, because one of these two potentially is more dangerous in terms of arrhythmic risk. So again, just paying attention here to the middle of a pattern, of the panel, sorry. So this is the notch pattern, and this is a slurred pattern. So what is the mechanism for early repolarization? The truth is, it's not really known. It's thought to be similar of that of Brugada syndrome. So let's just go back and talk a little bit more about cell action potential, because that's important to understand the mechanism. So remember, in phase 0, there's sodium channel opening, and then phase 1, there's this very important channel ITO, or it's a potassium repolarizing channel, causes this notching down here, which correlates to the J wave in the EKG. We'll see why in a second. Then phase 2, which is mostly calcium channel entrance, and then phase 3, the potassium channels open again, causing repolarization. And then phase 4 is just a resting cell membrane. So why do we see ST elevations in a surface EKG? So in this model here, you see regions A and B under, in the LV here. And then there's a differential concentration, or it's just that the ITO channels potentially work better in one of the sections. And that causes the rate of repolarization to be slightly different. For example, here you see that region B in blue, the cell takes longer to repolarize, it stays longer in phase 2 compared to region A. So this is what's called a transmural voltage gradient, and this causes a current to occur, and this correlates to ST elevation in the surface EKG. It's important to differentiate between early repolarization pattern and early repolarization syndrome. This is similar to Brugada or other types of arrhythmias. That early repolarization pattern is just the EKG pattern that we already discussed without symptomatic arrhythmias. Early repolarization syndrome, it's both the appropriate EKG findings and symptomatic arrhythmias, mostly VFib. So for most of the time, even today in most EKG softwares, early repolarization, when you're clicking it, still says benign early repolarization, because it was thought to be a benign finding. As we see later, younger people have it more. This changed in 2008 when this paper by Haisegari was published in NEJM called Sudden Cardiac Arrest Associated with Early Repolarization. It was a case control study, and the cases were 203 subjects with idiopathic VFib, and they're compared to controls, which were 412 persons matched for age, sex, race, and physical activity. And they defined idiopathic VFib with very strict criteria. So much like our patient is somebody with no structural heart disease, no CAD, normal QT interval, no Brugada pattern after infusion of a sodium channel blocker, and no catecholinergic arrhythmias. So what they found is that in the cases, meaning patients with idiopathic VFib, 31% had early repolarization pattern in their EKGs, and only 5% of controls. And after adjustment of baseline covariates, the odds ratio was around 10. So cases were 10 times more likely to have early repolarization than controls. Then lots of other papers try to continue this. Just a little bit more on this one. The demographics of cases, meaning VFib patients with and without early repolarization, they were very similar. Patients with early repolarization tended to be more male. They're more likely to be male on average, 72% versus 54%. And they were slightly more likely to have sudden cardiac arrest while sleeping compared to no early repolarization. But we see that other activity, meaning normal day-to-day life, was the most common activity before VFib in both types of patients. Also, the duration of QT interval was potentially a little bit smaller in the patients with early repolarization, but both are normal, and it's not a very impressive difference. So mostly very similar cohorts. What they did notice is that the prognosis of patients, this is only patients with VFib. So the patients with early repolarization tended to have more VFib over 10 years compared to patients that did not have early repolarization at baseline. So that was also very important information. So not only patients with VFib were more likely to have early repol, those that had early repol had a more malignant course over the next 10 years. So then lots of new papers try to answer this question. So what is the natural history of early repolarization and its prevalence in the general population? So one of those most important papers is this one's called the natural history of early repolarization pattern. So this is only patients with pattern in a biracial cohort. And then they got the cardia, or the coronary artery risk development in young adult study. So this was the cardia cohort, basically. So what they saw is that out of 5,000 participants at baseline, 941, or 18.6%, had early repolarization. ER, for the purpose of this talk, means early repolarization on their baseline EKGs. So pretty significant prevalence, 18%. And then they asked the question, so what happens with time? So sure, many patients have early repolarization, early on. Do they retain this pattern? And they saw that actually most patients lose the early repolarization pattern. They don't retain that pattern in their EKG. So this is year 0. Definite early repolarization is represented in blue. And you see that it decreases a lot in year 7 and decreases even more in year 20. Unfortunately, the major source of bias in the study was the amount of missing EKGs. You see here is even more than half in year 20. But it did seem the case that patients were less likely to have definite early repolarization after 20 years. Then they tried asking the question, so what are factors that are associated with the retention or so of the early repolarization pattern? So first they checked for the difference between white and black patients. And they saw that on average, black patients were more likely to retain the pattern over the course of over 20 years. Many patients still lost it, but they were more likely to retain it than white participants. Most of the white participants by year 20 did not have early repolarization pattern. And then they did a multivariable regression analysis to check for all the factors that were associated with the retention at year 20. So as we said, black race with an odds ratio of 8, females were less likely to retain early repolarization. So males were more likely to have early repolarization after 20 years. Exercise duration was also positively associated, meaning patients that exercised more tended to retain early repolarization. And similarly, lower heart rates was associated with early repolarization. QT index, as we saw in the other study, interestingly, and Cornell voltage. So the higher the voltage, the less they were likely to have early repolarization at 20 years. And then this study tried to answer, so what are their long-term outcomes? So if you have one single patient with early repolarization on their EKG, what can you expect to happen with them the next many years? So this was a retrospective cohort in Finland with around 10,000 subjects, and the primary endpoint was death from cardiac causes, and secondary endpoints were death from any cause or death from arrhythmia. The mean follow-up was 30 years, and they stratified early repolarization according to the degree of J-point elevation meaning more than 1 or 2 0.1 or 0.2 millivolts, and either inferior or lateral leads. That's because the authors were trying to find a specific subset of patients that potentially had higher risk of arrhythmias than others. So this is what they found. So much like the other patients, male sex was again associated with having J-point elevation and early repolarization and LVH. In this study, it was positively associated. The other study was negatively associated. I think that may be related to how they were including or excluding early repolarization. But the most important thing of this study is that, so this is a table 2, and then they trying to find the odds ratio for incidence of death from cardiac causes, death from any cause, or death from arrhythmia. And they saw that in the inferior leads, those are the only leads that were actually associated with all 3 outcomes. So you see that the odds ratio after multivariate adjusted relative risk was 1.28 in patients with 0.1 millivolt elevation, and 2.98 if the degree of J-point elevation is more than 0.2 millivolts. And death from arrhythmia, pretty much similar. So the relative risk was 1.4 if the J-point elevation was at least 0.1 millivolts, and 2.9 if it was at least 0.2 millivolts. And it was not statistically significant here if it was the inferior leads or the lateral leads, even greater than 0.2 millivolts in the lateral leads, because you see cross 1 here, and the p-values were not significant. So this study seems to point out that inferior J-point elevation or inferior lead pattern, early repolarization pattern, seems to be the most risky, and this is, remember, what our patient had. Then they did Kaplan-Meier curves for death from cardiac causes and from arrhythmias, and again, comparing patients with and without J-point elevation, this time with at least 0.2 millivolts in the inferior leads. And you see that patients that did have J-point elevation fared much worse over the next 30, 40 years compared to patients without J-point elevation. So it's potentially a marker of poor prognosis. Then they tried to compare J-point elevation to other causes of known cause of sudden death. So for example, prolonged QT interval, the relative risk was 1.2, LVH 1.16, and J-point elevation was more or less in that ballpark, 1.28, and even potentially higher if the J-point elevation was greater than 0.2 in the inferior leads. So this is potentially a risk factor for arrhythmias in the same ballpark as prolonged QT interval, which we definitely are concerned about when we see a patient with that. Then other authors try to continue to search for other factors that potentially found a greater risk subcohort. So in this study, having both J waves and horizontal or this descending ST segment, basically the slurred pattern, yielded an odds ratio of 13.8 for having idiopathic VT. Unfortunately, this wasn't replicated in other studies, but potentially the slurred pattern was also more dangerous. And then finally, in the ERIC study, this study called long-term prognosis associated with J-point elevation in a large middle age biracial cohort. Again, still trying to understand the same thing. What is the natural history, and what factors associated with J-point elevation and sudden death? So you see that here they stratified patients according to race and sex. So they saw that for Black males, early repolarization did not seem to confer any more risk. But for white females, definitely so, with an odds ratio of 8 for increase in sudden death. So this is plotting here. This is white patients, and this is Black patients. So it's white patients, white females with and without J-point elevations, white patients with and without J-point elevations. And you see that, especially comparing the females here in the solid line, females without J-point elevation tended to have almost no arrhythmias, and this is much different compared to patients with early repolarization. So potentially, if you see women, especially white women, with this pattern, it's more dangerous than in men. So I told you about a lot of studies. So if you meta-analyze all the studies that try to answer this question, what do you find? So this is what this paper from Jack from a few years ago tried to answer. So first you see there's massive heterogeneity across the studies. So from death from all causes, it went from being protective to being very dangerous. The pooled analysis was not statistically significant for death from all causes, death from cardiac causes, but for death from arrhythmia, it did seem to confirm an increased risk. That meta-analysis is also interesting because it allows us to focus on the absolute risk of having this pattern, early repolarization pattern. So the absolute yearly incidence of sudden cardiac arrest was 0.07%, or 70 cases per 100,000 person years in patients with early repolarization. And as we'll see later when talking about management, this is really the problem with early repolarization pattern. It is a marker of increased risk of sudden death, but because the baseline risk is so minuscule, even if you have 10 times almost zero, you still come up with a very low number, right? 0.07% per year, it's not a very high incidence. So let's talk about the management. So yeah, this is really the big problem, because even if you see a patient with early repolarization pattern, it's hard to know what to do. Definitely shouldn't place an ICD on everybody because their absolute risk is so small. So what do the guidelines say? So the guidelines give us a lot of leeway in terms of what to do. I think it's important to focus on the class 3 recommendations, basically what not to do. So the guidelines do say that if you see early repolarization pattern or an EKG on an asymptomatic pattern, there's a class 3 recommendation for further evaluation. It makes sense because those patients are at such low risk of having deadly arrhythmias that if you just see the pattern, there's not much else to do. This may change in the future as risk models become better, and maybe we can find a very, very high risk subset of patients, but it's still not there, at least in the current guidelines. And in patients with aborted sudden death or resuscitated VFib who have findings of early repolarization, programmed ventricular stimulation performed on the basis of ER pattern alone is not recommended. So what does this mean? Basically, if you have somebody with sudden death and early repolarization, you shouldn't change your management. So your decision to do V-stim should be the same regardless of whether they have the pattern or not. Now, in patients with unexplained syncope, incorporation of the presence of early repolarization findings is not well established. This may be a little bit different in other guidelines, as we'll see in a second. So for ICD implantation, just coming back to the unexplained syncope. So it's not well established, but if you have a patient with syncope and early repolarization pattern, later in the text, it's reasonable to take that into account as much as potentially you would take into account maybe a prolonged QTC, for example. But again, that's not as well established. So what about ICD implantation? So patients with early repolarization syndrome, meaning patients that had the pattern and survived cardiac arrest, they should get an ICD. Well, that's obvious. Quinidine, in addition to ICD, can be useful in secondary prevention for VFib in patients with early repolarization syndrome. This is what our patient ended up receiving. And isoproterenol can be useful if you have VT storm or VFib storm in patients with ER syndrome. And then this is similar to other types of arrhythmias. And then ICD implantation may be considered in patients with symptomatic family members of early repolarization patients with a history of syncope in the presence of ST elevations of at least 1 or 2, especially in the inferior leads. So the guidelines are already starting to accept that potentially these patients with inferior ST elevation are at greater risk. So you may consider it in this if you have symptomatic family members. It's a class 2B, so it's reasonable. You don't have to place an ICD, but it's not unreasonable either. And lastly, ICD implantation is not recommended in asymptomatic patients with an isolated early repolarization EKG pattern. Hopefully that's obvious by now. So in conclusion, early repolarization pattern increases the risk of arrhythmic death, but the absolute risk remains very low, which complicates management of patients with early repolarization pattern. Inferior greater than 0.2 millivolts early repolarization pattern is the most risky, so you should potentially take that into account, either in patients with syncope or patients with a family history of sudden death. And future risk models are being made, hopefully, to try to find a very, very super high risk subcohort that maybe we could consider ICD for primary prevention, but we're definitely not at that point yet. And for my acknowledgements, I'd like to thank Dr. Hirsch and Dr. Al-Shami for the help with the presentation and in the patient case. And I'm happy to answer any questions you may have.
Leo, is such an interesting talk. I just had one question, actually. When you were listing the factors that are associated with the retention of early repol pattern, they seem to match very much in my head to the factors that would be associated with retention of lean mass. Like people who are pretty much stay slim retain the early repol pattern. Is there any comment on that anywhere that you could have seen, or it's just my imagination?
That's a good question. Yeah, exactly. So there are two theories I saw, but none of them are exactly. One is just if you have a very obese patient, you may just not pick up an ST elevation, which I don't think is the case. Athletes do seem to have more early repolarization pattern. Now, why that occurs, it's not well known. And even, for example, in patients with LVH, one study shows that LVH it's negatively associated, the one positively associated. So as far as I know, I'm not sure. It's just not established.
Leo, great presentation. Quick question: is there anything in the guidelines on the use of, quinidine? You mentioned the use of isopril, which we do use in Brugada syndrome because its effect on the calcium current. But quinidine is established for patients with Brugada, and in our patients we use quinidine because it's this kind of very similar mechanism. And interestingly, in this patient, when we put him on quinidine, the ST elevation just went down.
Yeah, I'm trying to find the exact slide that talked about the quinidine, but yeah, exactly. So it does seem to resolve in some patients the ST elevation, and it goes along. Maybe the underlying mechanism for early repolarization and Brugada are similar, and it makes sense that quinidine would work for Brugada and early repolarization. Yeah.
Thank you.
Hey, Stan Sherman. There was, at the beginning of your talk, you talked about the different types, whether it be the smooth type or you had a little upward wave at the end. Was the final summary that it doesn't matter which type?
So, unfortunately, there are many studies comparing this. It does seem to be the case that the slurred pattern, not the notch pattern, the slurred is more dangerous. I found that study with an odds ratio of 10, so very, very dramatic effect. But it does seem to be the case. Other studies found, smaller effect sizes, but the slur pattern does seem to confer more risk compared to the notch pattern.
But it didn't say that if you had a slurred pattern or notch pattern that was over the 2 millimeters, it just doesn't matter. Is that right? That if it's over 2 millimeters, that's the most important.
Yeah, yeah. And the 2 millimeter cutoff in the inferior leads, that's what made it to the guidelines. So yeah. Mhm.
Leo, how did you guys know that this wasn't like CPVT in this guy that was playing basketball? You know, even though he had early repolarization.
Yeah, it's sorry, I couldn't I'm not sure if I understood if which
Sorry,
diagnosis.
how did you guys? I mean, not that it necessarily matters. How did you guys know this guy didn't have like CPVT in this guy that was playing basketball when he arrested it? If I heard the beginning right.
Yeah, it's a good question. He didn't have exercise stress testing, but nothing else in his history or in his hospital stay suggested that that was the case. But you're correct to say that, for example, in the first study that they defined idiopathic VFib, they did do stress testing on all patients to see, trying to induce arrhythmias. That it didn't happen in our patient, but didn't have history of palpitations or other episodes of syncope, during playing sports. But you're correct. We didn't do a specific evaluation of with doing stress testing, treadmill stress testing for that.
Like I said,
Yeah,
I'm not sure it matters. Go ahead.
I mean, it matters because we put the guy on quinidine. You know, if it was CPVT, the main treatment is beta blockers plus or minus flecainide. But the ST elevations were so prominent in this gentleman. I mean, he was cath. Like the first thing they did was just cath for STEMI, and that was the only abnormality on the EKG. You know, another thing is, his Asian descent, where Brugada syndrome is very prominent. So we were kind of between those two. But with the procainamide challenge being negative and the predominant EKG of ST elevation, we felt that's probably going to be early repo. But you're right, the part of the workup could have been an ETT to look for polymorphic VT and PVCs. But the EKG pattern and the response to quinidine probably just suggests either early repol or some atypical Brugada.
Very good. All right. Well, I agree with you. I mean, I was just playing devil's advocate. It seems pretty straightforward to me too. But anyway, if there are no more questions, thank you to Leo for an excellent talk on a topic we don't get to hear about very often. And I want to thank everyone for their attendance and continuing to support Fellows Conference on Friday morning. And we'll see you guys, I guess, 3 weeks from today in early January. Everybody have a fantastic holiday break.
The preceding program is copyrighted by Emory University.